Welcome, everybody. I wanted to start with this picture of Dr. Whittier, myself, Dr. Glassick, and Dr. Biff Palmer at the NKF. We uh, had just an absolute blast playing golf together. It's kind of funny how this all came together, but I'll spare you the story. But Dr. Glassick was kind enough to find us a course, and it was quite the foursome. I will say that Dr. Glassick shot his age. For those that are golfers, what that means is you have a score under your age, and you either have to be an incredible golfer or be a really good golfer and live long enough, of which Dr. Glassick is both. And he shot his age, which personally I've never seen happen before. It's pretty epic. He is 90 and he shot at 89. We had a blast, and we've decided this is going to be a new event. Any conference that we're at, assuming the weather permits, we're going to go and we're going to have the mean foursome that we are. So that was thanks again, Dick. That was just such a treat to play.
Thanks, Roger. It was really great.
Yeah, that was really special for all of us. San Diego, I think it'll be warm enough. So
Yeah,
there we
sure.
go. Welcome to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for May 23rd, 2024. This conference is being recorded. We do not have a CME code for today. We have nothing to disclose, and patient confidentiality is being totally preserved. Dr. Baxi is going to read us the case, and I'll take over from that point on. So, Pravir?
Perfect. Let me share the presentation via PDF on the chat. So in case you have some trouble viewing, give me a second here and I'll share it. All right. So our case today is an 80-year-old Hispanic gentleman who presented with recurring episodes of what he described as coughing up blood, and he was also experiencing shortness of breath during physical activity. His medical history was notable for hypertension, type 2 diabetes, and he also had a prior stroke, which has resulted in residual memory impairment. And he did have already a known diagnosis of kidney disease stage 4 based on his baseline creatinine levels of 1.8 to 2.1. We did have prior urinalyses, and those were inactive. There was dipstick positive protein, but I couldn't find any prior protein quantifications on file. Most of the history was kind of from his family, and he reported that over the last year he's lost about 15 pounds. His appetite has decreased, and his symptoms of hemoptysis began about 8 weeks ago, and he spit up, including blood clots and frank red blood, of course. And he initially, when this happened, he went to another hospital. His respiratory status was stable. He underwent a TTE that showed no particular etiologies. He had a preserved EF. He was seen by a pulmonary there with some workup, which we'll show, and then he was sent for outpatient pulmonary evaluation for outpatient bronchoscopy, given that he was stable at that time. Now he presents, prior to be seen there, he presents to Rush with still ongoing hemoptysis, and his shortness of breath has now worsened. He denied on further questioning, he's denied any other supplement use or over-the-counter, no non-steroidal use. On admission, his creatinine is 2.3, not too far off of his baseline, which I mentioned. His hemoglobin was 8.0, and reviewing his labs previously, his baseline was around 10, including the initial admission to the other facility. His urinalysis that we checked did have now protein and blood on dipstick, with about 10 RBCs noted on high power field. His urine protein to creatinine ratio was elevated at 4.3. His serum albumin level was 2.9, and we did get a CT scan that showed over here along with a chest x-ray, and you can see that there's evidence of ground glass and nodular opacities affecting both lung fields. In this admission, his respiratory status is not as stable. He's requiring high flow nasal cannula. So a bronchoscopy is done in the ICU, and this confirms diffuse alveolar hemorrhage. He started with treatment for with Solumedrol, and we were consulted. Other review systems that were pertinent: weight loss and I've already mentioned he was having fatigue and dyspnea and hemoptysis. Otherwise, his ROS was negative. His medical history, hypertension, type 2 diabetes, which has been diet controlled now. He did have this prior stroke, and he also had a vertebral stent, and so he was on Plavix long term. Hyperlipidemia, his surgical history, only significant appendectomy. His home medication listed here. He's on SSRI, Plavix, folic acid, iron, pantoprazole, 40 milligrams. He was on, and he was switched from amlodipine to isosorbide, dinitrate, and hydralazine just recently, but this was both started after he had already presented with hemoptysis. No current smoking, but he had a former smoking history. He quit 20 years ago, and nothing else pertinent in his social history. No family history that is important here. His exam, he was afebrile. His blood pressure is 140/60, which is approximately his baseline. Most notably was his requirement of high flow nasal cannula, and even with that, he was 91% saturation. On exam, although he was on high flow, he was awake, not acute distress. He did have bilateral crackles, and he had about trace to 1+ lower extremity edema on my exam, at least. No rashes, nothing else notable on physical exam. Laboratory data, his serum sodium was 133. Of note, bicarb 16, BUN 45, creatinine was up to 2.49. Sorry, not 249. That would be alarming unless a different, we were using the other units. Albumin 2.9, total protein 6.
I have to confess, that's my bad. It was 2.49, and I have a pet peeve about 2 decimal points for creatinine, so I went to change it. Instead of trying to make it 2.5, I made it 249. So
it's okay. Total protein 6.3. Really nothing else notable on LFTs were normal. His his hemoglobin is 8. MCV is 98.8. His iron studies are shown here. Iron sat 52 and ferritin was 1,000. Serological workup was done. Some of it this admission, and some of it was already checked just recently, given his recent outside admission. His ANA is negative, ANCA was negative, C3, C4 were normal. SSA, SSB negative. His rheumatoid factor is 18, which is just slightly elevated on our laboratory limits. Hepatitis, HIV, viral respiratory panel, anti-GBM, all these were negative. We even checked sputum AFB, that was negative. Legionella was negative. We had blood cultures, everything really negative. Bartonella titers were checked, and those were pending at the time of biopsy. UA, I've mentioned, he had protein in blood by dipstick, 10 RBCs with a UPC ratio of 4.3. Renal ultrasound had no hydronephrosis. Kidney sizes were 11.4 and 12 centimeters. CT I've already shown with a read of ground glass opacities in both lungs. The TTE, again, preserved EF, no other significant findings. And then we performed a kidney biopsy the next day.
any questions for Dr. Baxi? No, that's the first. Let's go ahead to our first poll then. So what do you think this patient has? ANCA negative vasculitis, and implying that the pathology via post-immune GN, IgA vasculitis, SBE with an infection-related GN, atypical anti-GBM disease, or antiphospholipid antibody syndrome.
Did you send off a cryo given the mildly elevated rheumatoid factor, or do we not have it available?
Cryo was negative.
Oh, okay. Sorry if I missed that.
No, I didn't mention it there, but it was sent out.
Everybody can vote. We don't see what your answers are.
Michael, our fellow, asked if SPEP UPEP. No, there was no SPEP UPEP at this time. Pretty good. 70%.
Okay, you can show the results. So we have the majority, over 2/3, think it's an ANCA negative vasculitis. We've got 14% with IgA vasculitis. Nobody buys SBE. I think Bill's question might have been pointed towards that. Atypical anti-GBM disease, we got 4 people, and antiphospholipid antibody syndrome, we have no people. So what I want now is for Dr. Whittier to tell us his thoughts, and if you could just keep that poll up so he can kind of address each of these, I think that's a good idea.
Yeah, thanks. Sorry, was there another question that I heard or no? No. Okay. So my first thought is actually that if I'm seeing this guy in clinic and he doesn't have this alveolar hemorrhage syndrome, he's got progressive CKD and a patient with diabetes. And he's never had an active sediment until now. So I think no matter what we're going to see is going to be a background of diabetic kidney disease. And it's possible that that's all we see. And he has something completely separate for his lung presentation. But when you hear diffuse alveolar hemorrhage and now new onset hematuria, even though his creatinine or GFR seems to be relatively stable, we have to invoke our pulmonary renal syndromes, and usually a lot of those can be figured out serologically, although many of them need a biopsy, not just for diagnosis, but also prognosis. So, looking at all these, we think about our classic pulmonary renal syndromes of the ANCAs. We've got good pastures. We would include, lupus. Some would include sarcoid just because it's got lung involvement, but that's not typically alveolar hemorrhage, or if at all. And then every once in a while you could have a cryo and with an infection too, like the endocarditis. And we would also see, especially since the Bartonella you said I think was pending. In the case you said the Bartonella was pending.
Yep.
So if we're going to really invoke one of these, I think no matter what, we're going to have some background diabetic nephropathy, but is there going to be a lesion on top of it that helps nail down the diagnosis for the systemic issue? Because it seems like his main issue is not necessarily renal failure as much as his alveolar hemorrhage. But that's another indication for a kidney biopsy, is not just figuring out the kidney part, but giving a systemic answer so that we can treat it so that he can breathe, for example. And that might be the backdoor way into getting the full diagnosis. So is it ANCA negative vasculitis? I mean, when you ask Dr. Falk about ANCA negativity, he's always saying that that no one's doing the ANCA right if it's negative, that ANCA negative vasculitis doesn't exist. But in the literature, it's about, I think, 10%. Whether that 10% is not doing it right, I guess we don't know. So that's a possibility. In talking about ANCA, would we also think about hydralazine induced? Yes. But what goes against that is, one, his alveolar hemorrhage seemed to start prior to that, I think, is what you said, Pravir. So that doesn't make much sense. And also, if it's hydralazine induced, you think about very high titer MPO, PR3 combined, you think about serology way more active than even clinical. And here he is the exact opposite. That is clinically way more active, and serologically he's so quiescent. So I would think the same thing for Bartonella. I believe that, and I'd have to check on this after reviewing the literature, and so I'm sorry if I'm talking here without backing it up, but I think that with Bartonella, there are often also high titers, and maybe even with cryo, and I don't really expect that, even though obviously the Bartonella is pending, which could be your little teaser to get us. Is it an IgA vasculitis? Well, he's Hispanic. He could have IgA nephropathy long-term as his baseline CKD, and then now he has an IgA vasculitis. I really don't think about that with pulmonary renal syndrome, but I'm sure that that's been reported. I usually would think about an IgA vasculitis as skin involvement, abdominal pain, your classic Henoch-Schönlein purpura type of presentation, as opposed to rip-roaring alveolar hemorrhage. But he was a previous smoker. And a lot of these things where you have a little bit of inflammation in a previous smoker can then accelerate the inflammatory alveolar hemorrhage. We think about that certainly for GBM disease, which is also down there. But again, his GBM's negative, his ANCA's negative. I don't know how often you could have GBM disease with a negative serologic GBM workup. His GBM was negative, right?
Yes, GBM was negative.
Yeah, so I'm sure it's been reported, but again, I think that's a minority. And then antiphospholipid antibody syndrome, I guess, could he be throwing clots and that's the cause of his alveolar hemorrhage? I think that's possible. So I'm really kind of in a bind here. I'm somewhere between ANCA negative vasculitis or GBM negative GBM disease. I mean, this is a real tough one. Or is it really just, like I said in the very beginning, two different disease processes that really have nothing to do with each other. And he's got background diabetic nephropathy, and he has something else in his lungs, whether it's, cancer or from his previous smoking, or if it's, something else altogether. But if I had to put one thing all together, I guess I would go against what Ron Falk said, which I've told myself to never do in my entire lifetime, and say that it might be ANCA negative vasculitis.
That's good. So Dr. Reen has a question. Before that, I do just want to say the antiphospholipid antibody syndrome, there is an association with pulmonary hemorrhage. It's not common, but it's well described. Kind of put up there. I think it might be a little too esoteric for the fellows, and it's not just with pulmonary embolus. But I don't think anybody picked that, but it's kind of in the differential diagnosis of pulmonary renal syndrome. Dr. Reem?
I have a comment on about atypical anti-GBM. Actually, there is a Dr. Glasses can chime in there. If it is IG4 related anti-GBM, which will be negative by usual tests what we do, and if I recall, they are universally associated with pulmonary hemorrhage. So I think it shouldn't be called as atypical anti-GBM. If you do the Western blot test, then it can become positive. I think Dr. Glassick is more expert on that. He can comment on that.
Well, not only is Dr.
Well, I
Glassick,
think,
not only is
I
he
think
more,
Dr.
let me just introduce you, Dick. I mean, not only is Dr. Glassick more keen on that, I think he's written probably more about this than anybody in the world. So Dick, walk us through atypical anti-GBM disease and what the antibody might show and the testing and everything, please.
Well, thanks, Roger. And I think Dr. Remus pointed out an important distinction. Atypical anti-GBM disease, by definition, does not have pulmonary hemorrhage. So the two words are kind of incompatible with each other. None of the cases that were included in the original description or subsequently have had pulmonary hemorrhage as a presenting feature, diffuse alveolar hemorrhage. So let's try to use the term atypical anti-GBM disease in its proper, more restricted way, which presents as a renal limited disease. The second point is I've seen a lot of patients with anti-GBM disease, and I must say I've never seen a patient have clots when they had hemoptysis. Now, I'm not saying that that rules out anti-GBM disease in the classic sense, but my own experience is that clots are not a part of the syndrome. The bloody hemoptysis can certainly be seen coming from both bronchi, but they're not associated with clots in the bronchi. I hope somebody else will come up and contradict me, but that's just been my experience. The other point is we have a patient with a heavy smoking history and weight loss, unintended weight loss, and hemoptysis of 8 weeks duration without any iron deficiency anemia. I wonder whether this could be lymphangitic spread of cancer in both lungs. I'm just thinking that this is something that we have to consider, particularly because of the clots. And the other point, I'll just make it briefly, is that Roger and Bill mentioned anti-phospholipid antibody syndrome, and that's absolutely correct. The syndrome of diffuse alveolar hemorrhage always includes patients with primary antiphospholipid syndrome, even without lupus. The exact mechanism why this occurs has never been firmly established, but it is a distinct association, and probably it would be worthwhile knowing what the antiphospholipid antibodies are in this patient, because that would raise the possibility of some underlying thrombotic microangiopathy in the kidney, although there's no other manifestation of that. I would be very surprised if this is linear immunoglobulin along the capillary wall, I think it would be exceptionally uncommon. But I can't absolutely rule it out. It's just that I don't think that this is atypical anti-GBM disease. Now, there are assays for anti-GBM disease that can be negative in the presence of antibody, particularly IgG4 anti-GBM, which cannot be detected by the conventional assay. So the biopsy will give us that answer, because when you stain it with subclasses, it's IgG4 exclusive.
So so you don't call that atypical, since atypical is reserved for no pulmonary hemorrhage. It's linear IgG without pulmonary hemorrhage. What is there a name for that is it false negative anti-GBM disease, or you just have to be a little more sensitive to that possibility?
Well, I mean, if the patient really has diffuse alveolar hemorrhage and has a truly negative anti-GBM with all the sensitive techniques, including a Western blot assay, I guess you'd probably, and it shows linear fluorescence, I guess you'd have to label this as atypical anti-GBM disease, but this would be an exceptional case. Maybe the first case ever associated with diffuse alveolar hemorrhage.
But
So
Dr. Glasser, can you comment on pulmonary hemorrhage associated with IG4 related anti-GBM disease? My understanding it is universal finding in there.
Yeah, it's very uncommon, as you point out. It's mostly renal limited disease. I haven't read the literature recently, but I think there's been 1 or 2 cases of pulmonary hemorrhage associated with IgG4 anti-GBM disease with negative conventional assays in the serum, but I'd have to check the literature again. I may be wrong.
I think, Dick, we both went through why we didn't think it was all of these things on the poll, and I put my nickel down.
Yeah.
But I didn't hear you put your nickel down. We got to hear
Well,
what
I just I would guess that antiphospholipid antibody syndrome would have to be in the differential, but from what we know right now, I would say ANCA-negative vasculitis, even though pulmonary hemorrhage in that circumstance should not produce clots. So, and I added the cancer diagnosis, mainly because of the weight loss and the heavy smoking, and this would certainly not be a common presentation. The X-ray is not typical of cancer, but it could be lymphogenic spread involving both lungs.
Great. Any other comments? Any other thoughts? All right, let's see who's going to read this biopsy. We'll turn to the wheel.
It's going to be particularly troublesome if it's just showing diabetic kidney disease and nothing in the kidney as far as inflammatory. Then we're going to have to really figure out what to do for this person, lung biopsy or something.
Well, Bill, you brought up a good point, Bill. Originally, when you said, this could be just diabetes, I mean, certainly no one would be surprised if there's diabetic background, but you bring up a good point, because, it wasn't even, normally I should put anything in the poll that's even reasonable. And I always leave something out, not purposely, that maybe I should have put diabetes alone, because that's, and he could have had something else. The reason I didn't put diabetes in there, not because of giving anything away or trying to mislead anybody, but it's just this pulmonary hemorrhage story was so impressive.
Right.
Going on quite a while. He wasn't anemic. He wasn't iron deficient, as Dr. Glassick pointed out, but he was pretty anemic. And it had been going on quite a while. So and it was there on CT and it was there on bronchoscopy. So I really kind of focused at least the quiz on the pulmonary renal syndromes, but it's always a good point.
Yeah.
All right, Will. It picks Dr. Hyde. I think he's going to quit fellowship.
All right, Steve.
Well, Steve, you can't quit.
Yeah.
It seems to be the wheel just loves Dr. Hyde.
All right, Steve, can you unmute yourself, see if it works?
I couldn't have predicted that.
I think there's a magnet there. I think Bob and Michael have put a magnet next to his name. Steve, you need to get a little tricky and put the magnet over their names. Or a weight.
Can you unmute yourself, Steve? See if it works. Can't hear you. Can't hear you.
This is the way he gets out of it.
Yeah.
He moves
What
his
about
lips
now?
but doesn't speak.
Can you hear me now?
Yeah.
Yep. Yep. So, I'm going to give you control here. Go ahead. Yep. You're controlling. There you go.
All right. So we have a trichrome here, 3 cores, pretty good sample. I can see some glomeruli here. As far as fibrosis, probably about 30 or 40%, I guess, consistent with patient's past history.
Yeah, Steve, that's a good read of the trichrome stain. Yeah, I agree with you. We have a good sample, actually 90 glomeruli. So that's so far that's the record for the year.
Yeah, it's the most that I've seen.
Did you say 90 glomeruli?
Yeah, 90.
Boy, that's got to be a record.
Yeah.
So we have a PAS here. I can see 3 gloms pretty clearly. Overall, I mean, just looking at the PAS here, you can see that it's certainly staining darker in some of these areas of nodularity. Not really seeing a whole lot within the tubules themselves, but take a look at a higher power here too.
Yeah, so the glomeruli would be like descriptively a nodular glomerulosclerosis, right? Yeah.
Yeah, that's what I would say.
Yeah.
Most specific here, and then, but you're seeing some here as well.
Yeah. And no crescents or necrosis or anything necrotizing. Yeah.
Especially
And-
with the ANCA vasculitis on our differential, and you're looking for crescents and anything there. You don't see that.
You know, you'd argue that even the one in the bottom left there sort of looks like it's got dilated capillaries around the large nodule and really might be consistent with KW. But obviously we'll wait on some other stains.
So higher power of a single glom here. Just looking at the glomerulus itself, definitely seeing a lot of nodular sclerosis. The nuclei are definitely surrounding these areas of sclerosis, which I would say is more consistent with a diabetic nephropathy sort of picture. Seeing a lot of red blood cells outside of the glomerulus. And then over here, kind of in the 3 o'clock position, this looks like an arterial disorder.
Yeah. That's a large interlobular artery there, and it looks okay. No fibrointimal thickening. Okay. Yeah, I mean, mesangium's really expanded throughout with these nodules as you described. Yeah,
But not necessarily with hypercellularity. I mean, I think it's
Right.
expanded. All right, so another H&E here of a single glom. Same sort of picture, again, seeing the nuclei kind of lined up along with the outsides of these areas of sclerosis. And then, but without significant hypercellularity. So a lot of mesangial expansion, that same kind of thing.
Steve, what in terms of nodular sclerosis, there's a differential, and I know what this patient has 2 things that kind of jump out. What are those things?
I mean, you're thinking specifically about diabetic nephropathy, right? With, KW nodularity and that sort of thing. I mean, the other thing that kind of comes to mind specifically with on the PAS from before is something like amyloid, which I mean, we need to see the EM in order to make that definitive diagnosis or kind of the red state.
How about the smoking history? So sometimes they can get idiopathic nodular sclerosis that way too. So that would be also on the differential, along with exactly like you said, amyloid or light chain or deposition disease or diabetes. Now he has diabetes and he has a smoking history, so potentially.
So we got another PAS here. I mean, I guess in terms of PAS positivity, it's kind of weekly PAS positive throughout, but a little bit more saturated kind of in the 12 o'clock position that I'm seeing in these areas. Is that something you'd agree with, Dr. Stumble?
Yeah, it's interesting. It's kind of mosaic. There's kind of weekly positivity in the middle, and then on the peripheral areas, it looks to be more intense. Interesting.
Yeah. And then can you kind of describe what's happening with the tubules here? I mean, they look, is this just having to do with the processing?
Yeah, probably a little fixation artifact.
Okay.
Yeah. They start to autolyze quickly if they're not placed in formalin right away.
Okay. And then we've got another PAS just showing the same kind of pathology throughout here.
Yeah, definitely a lot of mesangial expansion in this material. And then we have the hilum there at 4 o'clock. Yeah.
In this position.
And
Yeah.
a feature of diabetes is hyalinosis of afferent and efferent arteriole. So it looks like we do have that there. Yeah.
Yeah.
Both of them show some hyalinosis.
And you're saying that in diabetes specifically, it's typically both the efferent and
Yeah.
afferent.
Yeah. Whereas in hypertension, it's just the afferent.
Right. All right. So going to the silver stain here, specifically looking for things like spikes and holes. Not really seeing that in this sample.
Yeah, the GBM itself looks smooth, and then there's all this mesangial matrix expansion throughout.
So this is kind of what I
Can you
was.
go back?
Yep.
Oh, up around 2 o'clock. There's that one there. There's almost some spikes there. Can I talk you into that at all?
Well, but that's the mesangial area, Robert. Roger, the capillary walls are anchored to that mesangium.
Okay. I was trying to talk Steve into it, not you.
Okay.
Just kidding.
So this, I think, is Congo red. And we are seeing some positivity throughout here, more specifically kind of around here at 8 o'clock and then again at about 2 o'clock as well. But kind of diffusely throughout this glomerulus and even within the interstitium as well.
Yeah. So that's
Are there any
the
vessels
Congo-
there, David? Are there? I'm looking for any. Is that maybe? No. Bottom right. Is there any arterioles? Would you see any like vessel involvement at all?
Yes. Yeah.
Right there.
I don't think in this
Oh, no.
picture, but yeah, there was vessel involvement.
It'll probably be highlighted when we do the birefringence too.
Coming up.
There we go.
Okay.
Holy crap.
Yeah.
Come
So again, pretty diffuse. It's actually funny. It's most notable kind of here, actually outside of the glomerulus, but diffusely throughout. I mean, I think that these, just looking back, these are the two areas that we're seeing specifically on the birefringence, that they do look to be a little bit more intense, but that apple green kind of color is more so outside of the tubules.
Yeah. So glomerulus, interstitium, tubular basement membranes, and vessels all involved.
David, do you usually see it in the Bowman's capsule? Or not typically see it in Bowman's capsule?
Not typically.
I think it's just remarkable how there's nothing in Bowman's capsule. Well, maybe a little slice there, but just about everything else in the kidney has it.
So getting to the IF at this point, I mean, there does look like there's deposition throughout, within the capillary walls, within the mesangium, within the capsule itself, and then outside in the tubular interstitium. So, which I think is more consistent with the history of diabetes than anything.
Good,
So,
Steve. Yeah,
well,
that's pseudolinear. Good.
I don't know. Good Pastures was on the differential.
Bite your tongue.
You need
mean-
to look at the albumin stain in the diabetic. I mean, this won't, an IgG won't help you very much without an albumin.
And then as far as kappa and lambda go, there's a little bit more hyperintensity you can see in these two, specifically the lambda, but not anything that's super, super impressive.
Yeah, kind of a little bit of trapping there. So yeah, there was no light chain restriction. So I couldn't diagnose AL amyloid from the
Right.
fluorescence.
Wow.
Okay, so coming to the EMs at this point, just on this image, it's actually almost kind of difficult to tell where the
I have a delivery at the dock. Delivery at the dock, please.
kind of hard to tell where the urinary and the blood spaces are, but I think that these are podocytes along this edge, so I was going to call that the urinary space, and then
Yeah, and you have a capillary, markedly thickened GBM, and then a capillary lumen right above that, with that
Right.
circle. Yeah.
just here,
Yeah, that's capillary lumen.
and then that's the same thing that's down here on the bottom, right?
Yeah. And then the rest of that is just all distortion from massive mesangial expansion.
And then this is kind of gives a better separation between the urinary space and the blood space, but again, significant expansion of the mesangial space and GBM. But the
Yeah, so Steve, right there, we're going to see amyloid fiber. I can also make out a little bit of fibrillary appearance right there. Yeah, intramembranous amyloid deposits there. But over on the far right, we have some diabetic changes. Yeah, the GBM is markedly thickened without any deposits there. So I think, yeah, there's a background of diabetic nephropathy, as Dr. Whittier had suspected.
So you're saying that this is more consistent with diabetic nephropathy?
Yeah, and up to the right a little bit, like from over there. You see that there's no deposits there, but it's markedly thickened.
Right. Okay.
He's just saying there's both.
Yeah.
And then getting finally to the higher power, where you can see the individual amyloid fibrils really dispersed throughout here.
Yep. And we don't get a measurement, but do you remember what the average diameter amyloid fibrils are?
Should be about 10.
Yeah, very good.
Yeah, we think about him as, haystack appearance or randomly arranged. Those are sort of the buzzwords. And it's almost alphabetical, the way you can remember the size of the fibrils. So amyloid is the smallest, and then it gets bigger as you get to fibrillary, and that's a little board's tip to be able to remember them.
Thank you. Sorry, anything else for the biopsy? Anybody else want to make any more comments on this?
No, so what's your histologic diagnosis?
Enough surprises already.
I think histologically, you have to call that amyloidosis and diabetic nephropathy.
Did you see any evidence of a plus immune or segmental GN or anything to suggest an inflammatory GN, which is basically everything on the differential except for the antiphospholipid antibody syndrome?
No, there's no precedent. There's no fibrinoid necrosis or anything along those lines. So that's definitely not what we're thinking about.
Yeah. So big surprise.
I suppose Roger would need to ask is this serum amyloid A, or is it light chain amyloid, or is it something else?
So let's ask our poll.
Because the findings so far just say amyloid. They don't tell you what kind of amyloid.
No, that's right.
Yeah, without light chain restriction, we don't know yet. Yeah.
Right.
So here's our next poll, which is kind of getting along the lines of that. Should we do a bone marrow evaluation for a clone? Should we do genetic studies? Should we do mass spec of the amyloid fibrils? Should we stain for amyloid A protein? Should we do pronase digestion, immunofluorescence of the paraffin block?
And interestingly, amyloid is also associated with capillary fragility. That's the classic raccoon eyes that you get on presentation. I don't remember hearing that in the physical exam, but you wonder if there's really amyloid in his lungs then, and that's his presentation there. It's clearly not anything else that we were thinking of as far as autoimmune. But you wonder if that's a possibility. I guess we also don't know what type of amyloid it is, which is why your poll is here. But, I'm also wondering if the certain types of amyloid, for example, transthyretin is more common cardiac, or, primary is more common in the renal. If there's one that's more common in the lungs, And I don't know the answer to that. I'd have to go through the literature. Like, is ALEC2, for example, common in the lungs, or is
I think
transthyretin?
I'm just remembering that I can't be 100% sure. Generally, people with myeloma may have pulmonary hemorrhage because amyloidosis, AL amyloidosis may involve lung involvement. So that's the thing I remember. Other amyloid, I don't remember causing pulmonary hemorrhage.
All right, let's show the results here. We've got a little bit of everything. We've got I guess number 1 and number 5 are kind of saying the same thing to a degree. We're just not believing that this isn't a paraproteinemia, even though we didn't have it and there was no light chain restriction, but occasionally we don't believe our immunofluorescence and we'll do pronase digestion or maybe go ahead and look for a clone. I think the real question is you go to genetic studies looking for something like ALEC2. Do you do mass spec of the amyloid fibrils or stain for amyloid A protein? I mean, certainly in the past we would stain for amyloid A protein. There's been arguments all over the place for different approaches. I'm going to take over the slides now and kind of go over some of the discussion that people just had about all this. You see here, I'll advance. So I'm jumping ahead because I have a lot of slides here. I don't want to go over too much, but so amyloid's a funny thing. I've always thought it's a funny thing. It's such a broad spectrum of diseases, yet it's described on a stain in a protein. But yet this protein that takes up Congo red has so many different, etiologies. It's just, and they're so diverse, from inflammatory to autoimmune to familial, etc. But what they have in common is this deposition, and as Bill pointed out, there's different amounts in different organs based on the type of amyloid. But since this is renal biopsy conference, we're going to kind of focus on the kidney. But they all have a lot in common. This kind of nodular sclerosis, which is or nodular deposition, which is non-cellular, and also PAS very weak is common but not specific at all for amyloid. They all seem to have Congo. I mean, by definition, of Congo red, but Congo red is a little bit operator dependent. I know that Helmut Reinke, he claims he won't even do Congo red. That he'll look at like the first slide and he'll go directly to some other test, whether it's amyloid A protein or mass spec. So there is some operator dependent on the Congo red, and sometimes we used to do a control. And there's also false positive that Congo red positivity has been occasionally described in fibrillary GN. But for the most part, these 3 slides here, and here's the EMs that and the Dick made this point. I mean, we're done. We're end up with amyloid. We don't know what the etiology of it is, because the EM of amyloid is going to look the same. There's these randomly, like haystack, as Bill pointed out, fibrils, and they tend to be about 10 nanometers, very randomly placed. And I mean, when you get to this, is basically what we are with our case. We don't have a diagnosis. We just have a pattern of injury. We went 49 minutes before we said pattern of injury. So here's all the proteins that have been shown to lead to amyloid. Probably not all of them, but we've seen a lot of these. Certainly AL, AH is, I kind of think of AL as AH, even though it's not, it's heavy chain. But I kind of put it in my own mind as paraproteinemia related. And then there's AA. We actually see a fair amount of AA here. There's transthyretin. I'll go over the relative renal risks of these in a little bit. And a lot of these are pretty rare. I think Bill had a recently apolipoprotein, one of the, was it number 2 or? Yeah, number 2, apolipoprotein 2, familial systemic amyloidosis, extremely rare, maybe 6 months or a year ago. And then some of these other ones that are obviously pretty rare. And beta-2 microglobulin is pretty much a dialysis disease. It's not really a glomerular disease or renal disease. This is a kind of a busy slide, but I want to point out this looks at where what diseases show at what organs. So Bill asked the question about lung, and if I can find it here, GI, larynx, pharynx, liver, lymph node, muscle, pancreas, prostate cell. I'm not finding it here. Spleen, tendon, thyroid. Did I pass it up?
No lung.
Is there any? Did I miss it?
No lung on this slide.
Oh, that's funny.
No,
So,
there is. There's lung right there.
There it is. Okay.
Where is it?
Right there with the pointer.
Yeah.
Is right there.
Okay.
Yeah, it's sort
Oh,
of
there
to
it
the
is. Oh,
right.
it's on the side. Yeah. So to answer your question, Bill, yeah, if it's lung, yeah, it's AL amyloid and then transthyretin, 13%. But I wanted to point out, I mean, from an amyloid standpoint, most of these, no matter what organ it is, it's almost always AL or AH. And um, the next thing, I want to go back, is that when you look at the kidney, most of these cases are AL amyloid or AH amyloid. But what's interesting is, ALEC2, I would have thought, from my experience, that AA amyloid would be more common than ALEC2 amyloid. And this might, reflect the demographics of where this is all being done. I mean, certainly we see a lot of AA amyloid in Chicago related to, gunshot wounds and chronic decubes and chronic osteo and the like. And we're probably a little biased about that, not to throw my city under the bus that's all this violence, but
Also heroin and skin popping is more common.
oh, absolutely. Thank you, Bill. Yeah, oh, of course. That's probably more than the gunshot wound. Yeah, thanks, Bill.
And this is a Mayo Clinic experience, which is I mean, not just Iowa, but obviously they have a wide, tertiary referral basis. But I also think what's really interesting in this is tell me in the kidney where you see transthyretin on this, which is the
Absolutely, it's absolutely not. And we had a case, case, I think, in the last year or so. And I said this last time when we had that case. Dr. Corbett did a CPC at the ASN Kidney Week many, many, many years ago, and it was I believe it was transthyretin, and which is interesting because it is such a rare renal presentation. And here's the transthyretin, again, rather with the heart, it's almost always transthyretin, and it's one of the few that really is dominated by that. But so there's a lot of cardiac amyloid out there, but not very much renal involvement. Here is the Mayo Clinic experience, and there's a lot of differences here. Here to the left is all patients, and then it breaks down to the paraproteinemia related ones, AA and ALEC2, which are the major ones. And there's a lot of significant p-values, but I'll tell you, I think these p-values are driven by the N, not by so much difference. So if you look at the age, even though it's a p-value, it's not really very impressive. Serum creatinine, on the other hand, there is a difference, and with the paraproteinemias, the creatinines are much lower, and some of these the creatinines are much higher, and I suspect it's because they don't have as much systemic involvement maybe, and they just kind of get caught later. I could, make different stories for A versus ALEC2, but certainly ALEC2, it's often picked up much later. It's often picked up as a very different disease than.
And just also ALEC2 is a lot more tubular interstitial, and AL are a lot more glomerular. So you'd imagine that a higher creatinine would be with the more significant tubular interstitial and scarring diseases.
And having said that, the proteinuria, I would have thought it is significantly different, but I thought it would be much more different. So for instance, ALEC2, which we typically do think of as interstitial, still, on average had, 24-hour urine protein was, 4 versus 6. It really is not, there's really not much here that tells us very distinguishing. Nephrotic syndrome, on the other hand, is, much more likely to be in the paraproteinemia related amyloid as opposed to some of these others. So, it's kind of confusing. And then when you look at this is what really surprised me, because this is exactly what Bill was saying, that I was taken aback by, because, here it tells, the interstitial versus vascular versus glomerular based on each of these type of amyloids, they're major ones. And, if you would have said, what do you think of ALEC2? I would have put interstitial way up here and I put glomerular way down here, but it really, there's a lot of glomerular and vascular disease with ALEC2, and it really doesn't look that much different from, for instance, some of these others. And so I was a little surprised, because I was under the impression it was predominantly an interstitial disease and maybe a little glomerular disease and wouldn't have any proteinuria. And at least from here, there's a lot of glomerular disease and more proteinuria than I would have thought that would be the case. So what did we do? We did mass spec, and this is how we report values at Rush. We don't use anything else other than texting. And this is what David says: Prevere the amyloid mass spec showed ALEC2 amyloid, which is now what we're doing. We used to do stain for amyloid A, but I think this is the way to go. Fortunately, Mayo can do it for us, and they did it pretty nicely. And so, indeed, this is ALEC2 amyloid. And I guess if you get back to the case, the clue, if there's a clue there, is Hispanic. but not a lot, we'll talk about the pulmonary hemorrhage towards the end here. So a little bit more about ALEC2. ALEC2, it's often called LEC2, but the reason is because the ALEC2 refers to amyloid LEC2, and the LEC2 is actually the gene or the protein. It's not synonymous. So that's kind of the nomenclature there. It's more common in Hispanics, but of course that's, what you see in America. Depends where the report comes from. It's also seen in Native Canadians, Punjabis, South Asians, Sudanese, Native Americans, Native Israelis, and Egyptians. And so, for instance, 50% of all amyloid in the Southwest USA is ALEC2, and 50% of amyloid seen in Egypt is ALEC2 because of that population. But that wouldn't be the case in Minnesota at the Mayo Clinic, even though they do get a lot of their biopsies from all over the country. There's been no mutations detected in the LEC2 gene, but patients, about half of them test positive for homogeneous for the G nucleotide and a non-synonymous SNP at position 172. I don't know what that means, but what it does mean is that there appear to be some genetic kind of basis for this. But having said all that, it's only occasionally familial. It's certainly seen more likely in certain ethnic or groups, but familial is very unusual, so it doesn't tend to run in families like that. That's more the exception than anything. So this is a study from Arcana and a little bit of New Mexico, I assume, because they have a lot of it down there. Of 414 cases of renal amyloid, 10% were ALEC2, but only 3% in the Mayo series, and that's kind of, again, I'm sure reflecting where they're getting their patient population from. It's not common. It's it's maybe 50% in Arizona, but when you mix it all together, it's a lot less across the country. I wonder if in Arizona they do biopsies in some of these patients. Most common, if it's a Native American Indian or something. Most common presentation was CKD, not nephrotic syndrome. That kind of does fit what our data showed as far as percent that present and how they present. The average CKD progression in this study was a loss of GFR of 6 mLs per minute per year, which is not insignificant. I would have guessed it would be a little slower than that, but it is not insignificant. Looking at a couple more of the tables from that paper, nothing really new here. Mean creatinine of 2.8, we saw that. I think these patients, because they're not presenting with edema, you're waiting, and they're presenting more with renal failure. That's a bias of how they present, that when you biopsy them. 40% actually had normal urine protein at the time of biopsy. Most common reason for biopsy is CKD, but there's a lot of comorbidity, a lot of past medical history of diabetes. Some have monoclonal gammopathy, but that's probably pushes them into biopsy as well. But 62% do have progressive renal failure, and another 29% have end-stage renal disease. This is hardly a benign diagnosis. Fortunately, it's not a diagnosis of your 30s or 40s. If you remember, the mean age was in the 60s, mid to late 60s, so that's the only good thing. And again, here's some of the pathology. So, glomerular, 88%, a lot higher than I would have thought. And, again, a lot of people can have something else. But what I thought was also interesting was this, was the notion that it's really not that, it's much more prevalent in the cortex and very meagerly distributed in the medulla. You can see the Congo red staining there in the cortex versus the medulla. But it does affect vessels, and we'll get to that because that may have something to do with the pulmonary hemorrhage. You can do a mass spec, which is what the Mayo Clinic did for us. There's also an immunoperoxidase anti-ALEC2 antibody staining, which shows, you can see these areas here where the ALEC2 is actually depositing in, this looks very similar to the Congo red. So this is not our patient, but looks very similar to the Congo red. But I think kind of what more people are doing now is they're just going to go, you have a case of amyloid, unless it's obviously AL or AH amyloid, you're probably going to automatically go to mass spec. So what about treatment? That gives you the answer to that. And, of course, we have a lot of other things out there like ACEs and ARBs and SGLT2 inhibitors and the like, but I don't know that anyone will ever be able to look at those specifically and do a trial on that. This is not common. I certainly wouldn't discourage that, but there is no specific treatment because we still don't really know what causes it.
And this certainly is not evidence-based, but I would say that, in familial Mediterranean fever, they talk about colchicine, and colchicine impairs the chemotaxis of leukocytes, and that's what ALEC2 is. It's leukocyte, chemotaxis. That's the definition of it. And so I've had a couple of these, and I put them on, not evidence-based, but I put them on colchicine as if I was treating familial Mediterranean fever.
And they're on dialysis, but they don't have gout, so.
There you go.
Just kidding. So getting back to pulmonary renal syndromes, and this is what, our whole discussion and because it really threw us off, and it should throw you off. I mean, you should be thinking of horses and not zebras, but, here's the diagnosis here. We've talked about all this. The one I would stress is never miss endocarditis, and that's why the rheumatoid factor was a little bit up. We did the anti-Bartonella titers, and sometimes only thing you'll find is an anti-Bartonella titer for that. And this guy had it it's a smoldering disease, and he had something going on for quite a while. So if you do a search for Casey Gashty, somewhere in the chart said something about ALEC2 and pulmonary hemorrhage. I did a Google search, and I came up with this ALEC2 amyloidosis presenting as pulmonary renal syndrome, a case report and review of the literature. And it's got an 84-year-old Mexican-American man with diabetes, hypertension, hyperlipidemia, presented with hypoxic respiratory failure, bilateral opacity concern for DAH. He had proteinuria, hematuria, some renal, and some renal insufficiency. And this is basically our patient. I mean, it's almost exactly the same. And they did find ALEC2 in this patient's lung. Although when I read further, the guy has an MPO antibody that was 385. It's kind of a misleading paper as far as I'm concerned. Now they were trying to, they weren't saying that it was or wasn't vasculitis, but it certainly doesn't make much of a case for ALEC2 amyloid giving you pulmonary hemorrhage when you've got an MPO antibody that's 385. Even though the renal biopsy did not show renal vasculitis or pauciimmune. But this came up a lot too, that apparently this is not an uncommon, I've never seen it, but there's certainly a lot of case reports of AL amyloid with pulmonary hemorrhage. And I just threw two up there just to show you. So, if I were to put this together, I still think that his amyloid was pretty impressive, and he had vascular amyloid, and he had, I believe that that's probably what was going on. He had pulmonary vascular amyloid with pulmonary hemorrhage. It isn't the ALEC2 per se, but it's just the amyloidosis that did this. And
were they able to bronch and see Congo red in the lung too, or we didn't get that far?
They couldn't get that far
Okay.
with the patient. They got the diffuse alveolar hemorrhage. They decided against doing any more pulmonary interventions in terms of biopsy or anything like that.
Sure.
Other thing one should remember, they can get superimposed infection, especially CMV and all those things, and they can present as a pulmonary hemorrhage too.
Yeah, right. Right. Interesting case.
yeah, big shocker for us, but a great learner for us. And, at least, something, you hope something good comes out of these cases. And I think from an educational standpoint, we can certainly make that argument, but still sad nonetheless.
Needing to add amyloid to my differential pulmonary renal syndrome is one of the things I'm learning here. I know it's super rare, but sometimes we need to keep these rare things in mind.
Yeah, an antiphospholipid antibody and amyloid, I think that's of value. And I want to say something, really quick, because I meant to do this when I talked about pulmonary renal syndromes. Bill brought this up, and when you look at pulmonary renal syndromes in the book, sometimes there's like tuberculosis, because you can have some urologic problems, and there's sarcoidosis, and I just really find that offensive to me. I think that a pulmonary renal syndrome should be a pulmonary hemorrhage and a GN, and not just all-encompassing anything that happens to be in the lung. Nephrotic syndrome with a pulmonary embolus, that's not a pulmonary renal syndrome. I think that it's the list we have, and I think I'd like to keep it that way, but that's my bias. All right, everybody.
For a teaching point, Roger, I think one is the differential diagnosis of diffuse alveolar hemorrhage is extremely long. And it does not include atypical anti-GBM disease. So for those who chose that, and I'm not I'm not criticizing them. I just want to point out that you don't need to consider atypical anti-GBM disease in the differential diagnosis. But on the other hand, the differential diagnosis is a very long, and you just added a LEC2 to the differential diagnosis. So it just got a little bit longer today.
And our MPO was negative. So
Yeah, exactly. Well, thank you, everybody. We'll be back in 2 weeks. Until then, everybody stay safe.